Hi, this is Nicole Kupchik, and I'm here with 10-minute tidbits. We're coming to you from Miami, Florida. We just attended 2 days of a conference called Chillin' at the Beach, and it's a conference all about targeted temperature management for both neuro injuries as well as cardiac arrest. So I'd like to introduce you to two of my colleagues. So Michele, do you mind telling everybody a little bit about yourself?
Sure. I'm Michele Deckard. I'm a clinical nurse specialist at IU Health Methodist in Indianapolis, Indiana.
And I'm Makayla Cordoza. I'm a nursing education specialist at Legacy Health in Portland, Oregon.
And they both have had a lot of experience with targeted temperature management, especially post-cardiac arrest. So what we wanted to do for you today is give you a recap of everything we learned. This conference has been just amazing and insane, just all the data that was presented. And so we want to update you with what we learned. So, okay, let's first of all talk about, I think, one of the biggest studies that was announced. It's called Targeted Temperature Management, or TTM2. So it's the TTM2 study. So some of you might have remembered hearing about the 33 versus 36 study that was published back in 2013 by Dr. Nielsen. Well, now they're studying another basically trial that's starting called TTM2, where they're comparing 33 degrees to 37.8. Basically, it's fever prevention.
Yeah.
All right, so what'd you guys think? I thought I was like, whoa.
I was too. I was very taken aback when I first heard about it, because it's like when you're so used to saying that cooling is what helps, you're sitting there going, why would you even think of doing this?
Yeah.
Of letting them get just to that edge of going into a fever. But once you hear about it, it's like almost to the point of, as a proponent for 33, I kind of like it in the fact that he's looking at just fever management versus 33. And I think the other point that I liked was that a lot of people who read the first TTM study thought that study was about fever management rather than actually targeting 36. So this may help clarify some of that about the 33 versus 36 versus just fever management.
Yeah, because there was a lot of confusion after the TTM1 trial. It was 33 versus 36. And 36, just to be super clear, is not normothermia.
No.
And a lot of people, I think, blew off and just stopped doing the protocol. And, it's been fascinating, because I think centers need to really track, if they decide to go to 36, they need to track their numbers. And so, I don't know, Michaela, what was your take on this TTM2 trial?
I agree. It's definitely extremely controversial and interesting. And I agree in one part that there's differing evidence for the efficacy of 33 or 36. And so theoretically it makes sense if you look at some of the animal and some of the non-randomized studies that adds more of a proponent for 33 or around using therapeutic hypothermia. I think, though, what's interesting about this is it's not, the original 2002 trials were looking at temperature management versus nothing.
Yeah, that's a good point.
This trial is looking at temperature management at 33, and I agree with what you said. But also, once the patient gets up to 37.8, then they're going to institute fever prevention using active cooling, so either surface cooling pads or intravascular device, targeting 37. And so you're actually getting some temperature management just at a normothermic range, which I think is very novel. And so that's why I am interested, and I think the world is interested in what is going to happen. Yeah,
I think my big concern is if this turns out to be a positive trial, I think people are going to completely blow off temperature management altogether.
That's true.
Because in the hospital, patients we think of fever as like 38.5. Some populations even 39, and we don't do anything actively until they get their temperatures are really high. And I'm super concerned if this turns out to be positive that this is just, I think we're going to take a step backwards. I don't know, that's my real life clinical concern. So
I do like that it's going to be such a big trial. I think it's going to be about 1,900 patients, which we've never had in cardiac arrest.
It's huge.
Huge.
Yeah.
Multiple centers across the whole entire Europe,
U.S.
a couple sites in the U.S., maybe Australia,
Canada, Japan,
and
New Zealand.
Yeah. They did talk about one thing also that was up for kind of hot debate is the rate of rewarming in that trial.
Ah, yes. Let's talk about that. That was you joke.
So we had lots of great, vigorous discussion. getting, you know, all these smart people in one room to talk about rewarming. And so I don't know that we've figured out the exact rate of rewarming. And so in the TTM trial, they had a max rate of rewarming at 0.5 degrees.
Which is super fast compared to most protocols. I know we're 0.15 per hour.
So are we.
You're 1.15. How fast do you
About
rewarm?
2.5, yeah.
About 0.2 to 0.25.
Yeah.
And the first trial, they rewarmed at 0.5. And I remember asking that question after that study was published. There was a big webinar and asking Dr. Nielsen, like, do you think that may have had an impact on the outcomes in the 36 group, or I'm sorry, in the 33 group? And, you know, and I don't know, they're going to rewarm a little slower, but I just wish they would just dial it back and take it to 0.15 and just, you know, just do it slowly, but
give them the best shot.
Yeah. So I don't know, but it's exciting. So it's I think they've already started enrollment.
Yeah, they started.
Yeah.
Mm-hmm.
So okay, so interesting.
Yeah, so they should complete data collection around 2020 or so, and then so we should be hearing in the next couple of years what the outcome of that study is. So interesting.
Yeah.
Stay tuned.
Stay tuned. Yeah.
Mm-hmm.
All right. What were some other big things you took from this conference?
I think some of my learning was in the stroke population,
That was
because I'm not
fascinating,
I'm not involved in the neuro population at all, and there's some very novel things going on for cooling in the stroke population. And I know in that population they've had difficulty in, you know, in saying what the efficacy is in that population. And I think there's some things that they're trying that may prove that will be beneficial in that population.
Yeah, so they're talking about possibly cooling in the interventional procedural areas versus waiting until post-stroke to manage temperature. So or bring down their temperature actually, which I think is fascinating. So, but the stroke now, with a lot of strokes, we're going more to thrombectomy and intraarterial TVA, and seeing just amazing results with that. So, okay,
And
all right.
They've already got the catheter in there, so why not
Yeah.
cool that area while they've got it in there?
Okay. The other thing, there talk about cooling cardiogenic shock patients, which I think is super exciting. So that's kind of coming. And then one of the talks I actually loved was it was a little more family and patient focused on just support groups and kind of the after hospitalization and like what patients go through. And one amazing Michele Gossip from Virginia Commonwealth talked about the program they have for patient support, and I thought she did an amazing job in really just relaying what patients and families go through after they have a cardiac arrest event.
Yeah, it is major. Yeah.
She really, I think, gave meaning to us trying to help patients recover. And so she hosts a support group for cardiac arrest survivors every month. And she shared some stories, and she actually asked the participants, what do you want us to know at this conference? And so she was able to share what actually survivors wanted us to know. And what they really wanted us to know is, one, they don't remember, and that could have been really scary.
Which is fascinating, because I think that's one thing we're always so worried about, right? Is them having maybe not so much memories of it, but bad memories, right? Okay.
And then she also talked about how there was just a lot of fear and anxiety both from the family. So if the family members did bystander CPR or they literally saw their loved one died, and we know resuscitation is quite gruesome, CPR and all of those things. So seeing that and then having to then like take care of the person that survived, and this big jumping off point between ICU, med surg, post acute care unit, and then home, and there wasn't a lot of bridging between the hospital to home, and that's where a lot of anxiety was happening with the family and the patient. Yeah,
and then also anxiety with patients having ICDs. After having a cardiac arrest. Okay. A couple other things I want to mention: ECPR. So ECPR and ECMO. So ECPR, for those of you who don't know, is the idea of using mechanical CPR. So think about a VFib arrest using mechanical CPR, putting patients on ECMO and getting them to the cath lab. And there were a couple of Japanese physicians who presented what they're doing in Japan. We've got a few people in the U.S. Dimitri Yiannopoulos in Minneapolis is probably one of the biggest utilizers of ECPR, but they were really showing the process that they go through, and they're very, very aggressive. And I'm seeing some decent results so far, and they're going to be launching a trial as well. So that was kind of exciting to hear.
It's interesting to see what the cultures, internationally are, because they're in Japan. They have doctors actually in the ambulances, and so
which is so different.
Yeah, so much different than what we do. And then they're actually even, going towards initiating the ECMO, in the field, so that very early on in the collapse of the cardiac arrest, they're already initiating it to get flow back again, which is, for those of us in the U.S., it's like, wow, that just blows you away that they have, doctors so readily available.
Yeah, and then there's just as an FYI for you, for those of you that are listening, in Paris, and there's I want to say Lund, but there's a couple places in Europe where they actually have these cars that respond to cardiac arrest out in the field if it's appropriate to assess patients for ECMO, which it seems like the earlier you get something support started, maybe the whole idea of preserving myocardium and getting them to the cath lab is possible. So okay, then the last big thing that I took away from this was fever prevention in brain injured patients. So be it stroke, intracranial hemorrhage, traumatic brain injury. So it sounds like there's a lot of exciting research that's going to be kind of ongoing, and maybe different methodologies instead of maybe waiting later to start temperature management, starting it a bit earlier, which I thought was pretty exciting, because we've been just waiting for something solid, in brain injured patients to really kind of guide us as to what direction we go. We know fever's bad, so just to be super clear out there, fever is bad. Do not let these patients that have strokes and intracranial hemorrhages and TBIs get febrile. And I think honestly, we are way too conservative in treating fever. We let patients get febrile all the time, and we need to stop. So and I'm talking about brain injured patients, not so much sepsis. So I don't want to get that confused. But in a brain injured patient, we need to be super aggressive. So
I think one thing also that was clear, or becoming more clear, is usually we start step one giving acetaminophen or some sort of pharmacologic intervention, and that oftentimes doesn't decrease your body temperature that much, or it takes time to start working, and so perhaps other things like temperature management could be used in that population to even be more aggressive and starting way earlier, because once they get the fever, the brain's being injured, and actually your brain is, brain injured patients actually warmer than your body temperature depending on location of injury, so your brain is actually a degree higher in some cases, and so being more aggressive I think is really important.
And I think one of them pointed out that you kind of almost need to go by trends rather than actual numbers.
Which I love that point.
Because if they're trending up, then guess what?
Intervene.
They're heading towards a fever, so intervene early.
Yeah, I think that was a good point. Like, do we have to wait till they get to 37.8 or 38 if they've had temperatures that are going up, over an hour? We know that they're going up higher, and so is there a case to be made to intervene when that trend, like you said, is going up versus when they hit a number, some arbitrary fever number?
I love that. And then one last point I will make for Graham Nichols, since he's from Seattle, is he really stressed a lot about his concerns about propofol and using propofol after a cardiac arrest specifically. There's some data maybe saying it can cause mitochondrial damage, and so just really putting some thought into the sedatives you're using for patients, and shivering strategies as well. So okay, so that's our recap from Miami, Florida. So I'm Nicole Kupchik, this is
Michaela,
and
I'm Michele,
and this is 10-Minute Tidbits.